Thank you for the invitation to attend and speak at this conference. So I'd like to talk about some early results. As radiation oncologists, we're a little bit behind the curve in terms of, thinking about focal therapy. But I'll present some results and also talk about some of the work that we've been doing at our center. So we know, there are long-term results in data now for whole gland brachytherapy, and so there's known efficacy as well as dose-response relationships which we could apply to focal therapy. We know that there's a reasonable toxicity profile, even with whole gland treatment. Obviously, there's room for improvement, which is why we want to get away from some of the morbidity of whole gland brachytherapy. And we can also validate our doses easily with post-implant imaging. And Dr. Katz asked about salvage therapy. Well, if you are using seeds, brachytherapy, well, they're easily identifiable to denote where you've already placed radiation. So one could theoretically come back and add seeds as a salvage procedure if you need to treat the untreated portion of the gland. So this experience from Harvard is probably the largest experience of what one could call focal therapy. I don't think it really resembles anything that anyone here would consider focal therapy, modern focal therapy. But it's, they treat a large number of patients, and Harvard has had a MRI-guided brachytherapy approach for a while. They basically targeted just the peripheral zone, sort of hypothesizing that that's where most of the cancers reside, and spared the anterior base using iodine-125. And they have long-term data with 12-year metastasis rates, but as you can see, those are probably not what we are looking for in terms of success and reduction in disease mortality. So there are a couple of other reports on focal brachytherapy, one from France. They treated 21 patients on a protocol with low-risk unilateral cancers. These patients declined active surveillance. They used MRI staging as well as transperineal saturation biopsies to identify tumor locations. And then they treated lesion with margin using iodine-125. And in their cohort, they had treated approximately 1/3 of the total prostate volume. And what they were able to confirm, as we have seen in other focal therapy experiences, is that morbidity was quite low. And they compared this to patients who had been treated with whole gland therapy, and they found that there was minimal change, a slight bump in the urinary IPSS scores at 2 months, really no change in sexual erectile function scores. So this was very well tolerated and proof of principle that focal therapy is associated with lower morbidity with brachytherapy. And they also found that the treatment of the prostate base actually was associated with higher IPSS scores, which has also been shown in a couple of external beam reports. Another trial, I believe this was Dutch, treated 17 patients with Gleason 7 or less tumors, PIRADS 3 or greater. And they used MRI fusion to implant a ultrasound visible marker, and that was what guided their therapy. They only treated with a 2 millimeter PTV margin, so that's probably too small, and we may see an effect of that in the results. And then they performed 1-year biopsies, and they successfully delivered greater than 95% of the prescribed dose to the index tumor in 16 out of 17 cases. And again, they showed that it was very well tolerated. Most of their tumors were small volume Gleason 6 cancers, even treated a smaller amount than the French study. And within the index tumor, there were no recurrences on their biopsy, but they did have a fair number of clinically insignificant cancers, as well as one Gleason 7, which occurred in the untreated parenchyma. So we've heard about some of the challenges of doing transperineal needle-based approaches with different modalities, and that's also true for brachytherapy. So it's been well shown that there are some challenges in terms of seed settling after placement, bleeding and edema, and needle displacements or deformations of the prostate, and that all can combine to make brachytherapy a somewhat challenging procedure. And this has been well documented to affect outcomes with whole gland treatment. So D90 is one measure of the amount of gland that you're covering, the adequacy of the dose. And if you look at outcomes and biochemical recurrences in patients with different D90 values, some people use a cutoff of 90%. You can see that this has a large impact on outcomes, long-term outcomes. And this has also been shown with biopsy data from Mount Sinai, where they showed that patients who received a high dose or a normal dose had pretty low rates of biopsy positivity at 2 years, whereas those who did not achieve an adequate dose had higher rates of positive biopsies. And we also heard earlier yesterday about learning curve with radical prostatectomy robotic procedures. And that's also true for brachytherapy. It's been shown that experience does increase the likelihood of getting a high D90. But these data actually suggest that even with experience in practitioners on the x-axis, 300, 400 procedures, 500 procedures under their belt, you still get a percentage of patients who are not going to reach that adequate level of D90. So it's probably a technical shortcoming. So there's been a concept of intraoperative dynamic dosimetry, which has been around for a while. Many of you, if you're familiar with the current brachytherapy method, there is what's called real-time tracking, where you sort of mark where the seed or the needle tip is as you place it. But by the end of the case, at least for the visible seeds, you may recognize that some of those seeds are not in the location where they were marked. So we've been working on a intraoperative dynamic dosimetry program, essentially using a very simple concept, stereoscopic x-rays, but of course the seeds show up on the x-rays, the prostate does not. And so even though it's simple in concept, there are many engineering challenges to come up with a system which will fuse that seed cloud from the x-rays onto an ultrasound. We were able to do that, and essentially, if you look at standard dosimetry, you may think that you've got entire coverage of the gland, whereas with our dynamic dosimetry system, there are areas that are located which are what we call cold spots. We've done an offline analysis of 47 patients where we just captured the x-rays and then compared to the post-implant MRI and CT and showed that this correlated very well with the dose. And we've also performed a clinical trial now on 45 patients using our dynamic dosimetry system. And essentially, if you look at the V100 or volume receiving 100% of the dose, you see that in the red, those patients had much higher V100s compared to our historic group of patients. And if you compare other parameters, dose to urethra and rectum did not increase. So we have a trial now looking at clinically low and intermediate risk patients using multimodality image fusion, including 3 Tesla MRI, as well as PSMA, our next generation PSMA agent, which is F18 DCFPYL. And we're going to use focal brachytherapy to target those identified lesions with follow-up MRI 1 and 2 years, targeted biopsies, and a repeat PSMA scan in 2 years. Thank you.